Hi, everyone, and thank you for joining our webinar today. My name is Jack Freestone, and I'm a postdoctoral researcher here at the National Centre for Clinical Research on Emerging Drugs. And I'd like to begin today by acknowledging the traditional custodians of the land on which I'm speaking to you from, which is the Bidjigal people. Sovereignty was never ceded, always was, and always will be Aboriginal land. And I'd like to extend my respects to any Aboriginal or Torres Strait Islander people who may be joining us today. We're bringing this webinar to you today in partnership with the Australian Illicit and Injecting Drug Users League, and AIVL is the national peer-led peak organisation representing a network of peer-based harm reduction and drug user organisations in Australia. And the title of our webinar is Community-Led Approaches to Drug Monitoring and Early Warning, Lessons from Around the World. As most people who are tuning in today will know that in the context of drug criminalization, unregulated drug markets are unpredictable, and in recent years, we've seen ongoing concerns associated with substances that are particularly potent, that might contain adulterants, or that are missold or misrepresented. And this really carries risk to the health and well-being and lives of people who use drugs. I think in this context, it's essential that we maintain and continue to develop our capacities for drug checking and analytic verification of concerning compounds, but that we also rely on and leverage the knowledges and benevolence of people who use drugs, who for a long time have demonstrated their agency and their capacity to care for each other around drugs and harm reduction. People who use drugs and frontline service providers are often the first to know when something's up with drug supply and are well placed to disseminate relevant and resonant messages and responses such as public drug alerts or other risk communications. So today we're presenting examples of community engagement within drug monitoring systems from Texas, from Vancouver, and also from here in Australia. We're going to have three presentations followed by a 20-minute Q&A. So please post questions in the chat as we go. And we're starting off with a presentation today from Texas from Dr. Casey Claiborne. So Casey, could you turn your camera on for us? Dr. Claiborne is an associate professor in the School of Social Work at the University of Texas
Recording in progress.
at Austin. Oh, I've got an echo there. And is the director of the Addiction Research Institute. Dr. Claiborne's work advances community-based and system science approaches to strengthening the opioid and addiction care continuum, and she specializes in designing digital ecosystems to improve care coordination and real-time overdose response, including the internationally award-winning TxCOPE platform, which is what Casey's going to be speaking about today. So Casey, I might hand over to you.
All right, thank you, Jack. I will share my screen. All right. Well, thank you, everyone. I'm very excited to be here and to share with you about our work building TxCOPE, which stands for Texans Connecting Overdose Prevention Efforts. Let's see. Okay, here we go. So this project, it was a 5-year-long project that we actually just finished the development and implementation. And it was funded through both the Texas Targeted Opioid Response Program through the state of Texas, as well as through federal funds through the Substance Abuse Mental Health Services Administration. Some of the components of this platform technically are illegal in the state of Texas. And so we did receive some donations through private funders to build out syringe exchange, as that is currently illegal in most municipalities in the state of Texas. Related to conflicts, I am a subject matter expert for the opioid litigation here in the United States, and my role in that space is to advise on health IT to abate the opioid crisis. So here in the United States, we've been struggling for over 20 years with the opioid crisis. Most recently, over the last 7 to 8 years, we've had drastic increases in overdose here in the United States. Fortunately, we did see in the last year about a 30% decrease in overdose fatalities. That doesn't necessarily mean that we are seeing reductions in the experience of overdose. It just means we're doing a much better job at preventing fatalities associated with this. I want to give a little bit of context to the location that this work was conducted in. So, in the state of Texas, throughout this project period and currently in the state of Texas, harm reduction work has significant challenges. We really take a public safety approach to serving people who use drugs. Um, from a philosophical standpoint at the state level as well as at the federal level here in the United States. And harm reduction, unfortunately, has some challenges associated with that. I think in the state of Texas, we have some strengths in harm reduction work. We have an amazing statewide network of harm reduction organizations, lots of trust between the community of people who use drugs and harm reduction workers and advocates. And we do a fantastic job from a harm reduction perspective, connecting people who use drugs to the services that they need. And the passion, the heart, and the resilience that we have as a community is just unbelievable, which is why I absolutely love the work that I do and grateful that I have the opportunity to do it here in Texas. On the flip side, we have pretty significant challenges from a policy standpoint. Like I mentioned previously, syringe service exchange is illegal in the state of Texas. Fentanyl testing strips, xylazine testing strips are also illegal. So you can see that we have some significant policy advocacy areas to improve harm reduction access. We also have very significant unstable funding. So many of our harm reduction organizations operate on shoestring budgets and oftentimes close their doors due to funding challenges. Other challenges, stigma, uncoordinated overdose response, and fragmentation of care are experienced across our communities as well. One of the things I love about this project is that we got to bring together harm reduction workers and advocates across the entire state. And we published this paper a couple of years ago. We do it ourselves, Strengths and Opportunities for Improving the Practice of Harm Reduction. And this was truly a community-driven manuscript, which was just, it was so empowering to see the community of harm reductionists here in Texas advocating for improving the practice of harm reduction. So, one of the challenges that we have here is that community really hasn't been included in our public health response for the opioid crisis and the overdose crisis that we have here in Texas as well as across the United States. One of our goals with the TxCOPE project was to harness that power within the community, so within harm reduction workers, within people who use drugs, and then be able to leverage health information technology to improve our data so that we have a data-driven overdose response across the state of Texas. So we developed TxCOPE, and I just realized that QR code is supposed to go to TxCOPE.org, and it may not, you may not be able to see this at an international level. I think we have parameters to where it's only United States based, but I can get you another website. So, what this project was, the state of Texas came to me back in 2019 wanting to improve data to inform our decision making and resource allocation for overdose response across the state because our data was fragmented. We had significant gaps related to overdose data and underreporting of both fatal overdoses and pretty much no reporting of non-fatal overdoses. And so they asked if I would work with them to build out a digital tool to help support data-driven community response efforts. So very early on, we knew that this could be a very challenging project. And so we wanted to make sure that we designed this in a way that was both ethical and responsible. We wanted to make sure that we're leveraging technology in a way that supports the community of people who use drugs and doesn't put them at risk. And most importantly, we knew that we needed to partner with harm reduction organizations, our outreach teams, and gatekeepers within the people who use drugs community who could really serve as advocates and guide every step of this process. And so our goal at the very beginning of this project was to give the community a voice so that they could inform how their data is driving public health response across the state. And we wanted to make sure that we're protecting the data that the community gives us and we're being responsible with that. So we had four municipalities who partnered with us as our community partners. And you can see here, I won't go through all of these, but we had faith-based organizations, we had outreach workers, we had emergency management services and fire departments, academic partners. I mean, you name it. We had public health leadership across our municipalities. So we had a very robust community engaged research design with this project. Our design process, we made sure, we wanted to make sure that this was built for the community and by the community. And so we engaged them in every single design aspect of the TxCOPE platform. The very first was doing preliminary research, which was led by my team at the University of Texas, but it was completely informed by our community advisory boards. And then we wanted to make sure our community advisory boards and our subject matter experts and people with lived experience that they were prepared and that they would feel we would reduce that power differential so that they would feel comfortable speaking and sharing their opinions and feedback. And so we did a preparation and training session, which then informed our full design process. And then you can see that our community worked with us all the way through dissemination, implementation, as you saw with that peer-reviewed paper that I showed previously. So I won't go through details for the sake of time for our research and development process. In short, we conducted over 150 interviews to understand gaps in the system. We wanted to make sure we had representation from all of the stakeholder groups, including people who use drugs, harm reductionists, and first responders. We did field observations with key outreach organizations and teams to make sure that we understood the system gaps as well. And then we took all of these data and the analysis from this data to our community advisory boards, and the community members really made the decisions for the design and development. Just very short, some key data gaps in the state of Texas. We have very disparate, uncoordinated reporting systems. We have our prescription drug monitoring programs, which are in theory supposed to be helpful for opioid response and data, but they're not connected to our EMS data, our fire department data. They're not connected to social services. Harm reduction organizations are completely left out. And it's also not connected to our emergency department data. So our data is very siloed. We don't collect data on key metrics like non-fatal overdoses. We also don't collect data on naloxone administration and distribution. And we really, Texas had a very big lag in understanding drug trends. Our data was about 2 years old by the time we really would see it and be able to make public health decisions, which is not helpful at all in a public health response during a public health emergency. And we also had a lot of data that we wanted to capture with TxCOPE from what we deemed as hidden populations. So these are the individuals who, after an overdose, don't access emergency management services. And they don't go to the emergency department or to the hospitals, which is a lot of people in Texas due to stigma and fear of legal repercussions. So, in short, all of these data informed the dashboard design. We knew privacy was key to the community, data sharing was really important, and we had quite a bit of themes, which are displayed here on the slide. We hired street outreach workers, not street outreach workers. We hired street artists, local street artists, to do all of our design and branding. We wanted to make sure that it was trustworthy. And when we talked to people who use drugs, they said, we'll trust the blue dot. So we like this logo, we like this brand, and then you guys need to brand. Lots of harm reduction gear that you can distribute out in the streets, which you can see here. So, what the TxCOPE platform looks like, we had an overdose reporting form. This is a very short snapshot of some of the components of the overdose reporting platform. This was publicly available, so community members would be able to access and report into the system. But our primary target user was harm reduction organizations as well as street outreach workers who would gather data from the community that is hidden and not accessing services historically, so that we'd be better able to understand drug trends as well as understand what are they accessing naloxone? Are there hot spots where we're not distributing naloxone, et cetera? The community organizations, our harm reduction workers, really wanted us to build out an outreach supply management portal. So they were tracking their supplies. If they were tracking their supplies, it was usually on an Excel file or they would say in a notes document on their phones. And so we built this out. We worked with them to build out an outreach supply management. And what this data does, they can customize their outreach kits. So they can, if they distribute safe sex kits or if they distribute overdose response kits, they can track their supply distribution and their kit distribution, and it maps on to where this organization is distributing and where hotspots are occurring. So then they can use data to better allocate their resources, and then also as an organization, they can better manage their supply distribution as well. So this is a snapshot of our state level data dashboard. All of the data I'm showing you guys is fake, just so you are aware. But you can see this helps us to show trends over time as to, are we seeing xylazine? Are we seeing medetonidine? Are we seeing where's fentanyl? Being suspected. And then you can see where overdose spikes are happening. We have an alert system built in, and in real time, what was amazing, I'll share one story. We had here in Travis County, which is where Austin is located and where I live, we had a mass overdose incident occur about a year and a half ago. And within 10 minutes, TxCOPE was alerted. We were able to send out a mass overdose alert between Austin and Dallas, which is about a 4-hour drive, and alert all the harm reduction organizations and outreach teams and EMS teams along that corridor. And they were prepared because we had found a bad batch. And the response was amazing. It was truly an incredible coordination of effort that was beautiful to see, inspired by TxCOPE. And this is our municipality level data dashboard. So it just gives a bit more granular data. All of these data are aggregated. So you have organization level data. So organizations own their data, they see their own data, but then we aggregate across all organizations enrolled in the platform. And this is what the aggregated data dashboard looks like. And then you can see our data ingestion strategy. So we incorporate data from all of the different data sources on the left. We haven't successfully done schools yet, but that's a work in progress and what we're hoping to eventually incorporate. And the idea is that by aggregating all of these data, then we have closer to real-time data instead of 6 months to 2 years lag time, and be able to make real-time decisions based on these data that can inform a targeted response. Our next steps are enabling AI. We've done some pilot tests for how to improve EMS data in our system and leveraging AI to do that, aggregating all of these different data sources, and then also looking at how we can better implement policy guidelines to support technology infrastructure for gathering data in this capacity. So I'll go ahead and stop there. Thank you so much for your time. Feel free to email me and reach out, and I look forward to the discussion.
Thank you so much, Casey. It's really inspiring work that you've presented. And thank you for joining us at your dinner time as well in Texas. We really appreciate it. A number of the things that you spoke about in terms of the co-design phase of the work really resonate with some of our experience here in Australia. So I'm going to hand over now to Molly Howes to speak about some of the work that we've been doing on the community drug reporting system in Australia. So Molly is the Director of Operations and Communications at AIVL. And as I mentioned earlier, AIVL is the peer-led organization representing peer-based drug user organizations across Australia. Molly, over to you.
Hi everyone, sorry, I had to stop sharing my screen there so I could unmute myself. I got ahead of myself. Thanks so much, Jack, and Casey. That was so interesting. That data dashboard is maybe one of the most beautiful things I've ever seen. I just wanted to start by acknowledging the traditional owners and custodians on the lands of which we're all coming from, and sovereignty was never ceded. I'm in Toogoolawah on the lands of the Yugara and Turrbal people in Magajin, Brisbane. And today, when we talk about the community drug reporting system, what we're talking about is the collection, interpretation, and moderation of self-reported drug experiences by community members to inform community care, harm reduction practices, education, and early warning systems, and then their communications. And I think, as we all know here, it's especially important today because Australia has the most contaminated drug market we've ever seen, and well-functioning early warning systems, including community insights and context from the community, are vital to responding to this growing risk. This kind of system has been identified as a need by community for a long time before AIVL and NCCRED kicked off this project in partnership with our co-designers. And I know some of you are here today. That's so nice to see you. And the community drug reporting system is going to provide insights about unexpected effects, increasing harms, acute and unusual incidents, and trip reports. But not only will it provide insights about the harms, it's also going to talk about or provide insights about neutral, pleasurable, and beneficial drug experiences. To understand the different perspectives and shape the community drug reporting system, we interviewed 20 stakeholders and then worked closely with 14 co-designers across 5 co-design sessions. All of the co-designers were recruited from within the AIVL network of harm reduction programs and drug user organisations from across Australia. In those initial interviews, we explored the stakeholders' experiences and perspectives related to their involvement in drug early warning systems in Australia and and interacting with community reported information. There was also discussions had regarding the feasibility of developing a nationwide community drug reporting system. And then we kind of moved into the thick of the co-design sessions, and those initial co-design sessions identified key principles and strategies that will guide the system's development. The co-design sessions also explored practical aspects of the system, including moderation, communication, and system outputs, what they would all look like. Then we worked on prototyping what the community-facing form could look and feel like with the resources that we had, and we also worked on the type of data it needs to collect to be useful and also to be accessible. On this slide here, you can see the double diamond logic model, which outlines the co-design framework that we used, and we implemented that alongside the overarching aims of the co-design sessions. In short, these aims were to explore the value of a community drug reporting system with the community, to identify the risks associated with a system like this, and to establish key principles and approaches to the design and the implementation. We don't have enough time to talk through all of the benefits and risks that the co-designers identified, but I definitely want to highlight a few of them. So one of the first benefits that people mentioned was the faster detection of emerging concerns or immediate risk. And this is just that people who use drugs know what's going on with the supply and with the markets way before clinicians, governments, and ED departments do. The second was inclusion of diverse community perspectives, and this is just the fact that we need to honour the altruism, agency, wisdom, and knowledge of people who use drugs, and providing options for community reporting helps us to do that. And then lastly, I wanted to mention just that bridging of the knowledge gap on new substances. We only know the effects of new and novel psychoactive substances because of community reports. Some of the risks that were outlined by the group were false or misleading reports, and this is something we had a big conversation around, that they could trigger unnecessary alerts, they could spread information or cause stigma. Obviously, the same as what Casey mentioned, privacy and data concerns, kind of the risk of data breaches or misuse by law enforcement. And then also low engagement, that If there's not enough participation from people who use drugs, then this system doesn't function. And obviously, criminalization is a significant barrier to participation and engagement in this system. In the first co-design session, the group generated four overarching aims, that the system needed to meet. And these were to establish a scalable and safe model for community drug reporting, to enhance engagement with and the quality of early warning systems by integrating the experiential knowledge of people who use drugs, to increase visibility of real-world drug experiences within early warning systems, and to improve the harm reduction responses of early warning systems and their stakeholders. And then after devising those aims, the group met regularly to consider the potential approaches to collect, verify, and moderate community drug reports, also to engage relevant communities and generate meaningful outputs from the system. And all of the approaches that were discussed often led back to a number of basic things, which we've grouped here as the 7 key principles. And these are that a community drug reporting system needs to be led by people who use drugs. It needs to be safe and confidential, equitable and accessible. It needs to be open to reports of pleasures and harms. Also to integrate with state and territory-based early warning systems. It needs to have a responsive moderation process. And it also needs to inform multiple outputs, not just drug alerts. So after that kind of initial values alignment phase of the co-design process, we moved into the prototyping phase. So on this slide, you can see a bit of a process flowchart, and this is kind of how the system is going to work in the back end. So at the top of the flowchart are the different ways community members can report information. And then all of the data that is collected through those forms will be stored in a secure online system, which is owned by AIVL and the state and territory drug user organizations. AIVL and NCCRED will review and sort all of the incoming data on a daily basis. So they're essentially organizing it to make sure that any emerging issues or warning signs are identified really quickly. And then when something concerning is identified, that information will be escalated to the relevant state or territory organization, and then those local partners will have the authority to decide what action to take. And then I just wanted to talk a little bit about kind of the bottom of the flow chart here, the reporting and the discussion process. So alongside data being sent out immediately, that's urgent. There'll also be aggregated reports that come out each week, and they'll be shared at the local and at the state level. And then each month, a national summary group will be shared with the national discussion group. And that national discussion group includes representatives from AIVL, the state and territory drug user organizations, the PRN or the Prompt Response Network, which is run by NCCRED, and then any other early warning experts that the group wants to invite in when needed. And that group will basically, it will operate as a community of practice, and its role is really to review emerging issues, then refine all of the response processes, and then strengthen those processes and the links between the community drug reporting system and then other existing early warning systems. And that group will meet regularly, but it'll be flexible. Meetings might be formal, or they can take place via email or phone discussions. And that national moderation process will work alongside the local level review process, and together they'll shape the outputs of the community drug reporting system. And those outputs, this is the kind of circle at the bottom of the flowchart. Those outputs might be harm reduction resources, drug alerts, public summary reports, workforce and capacity building training. We also have dashboards on there, which is why I mentioned Casey's beautiful dashboard, and evidence briefs as well. From there, once we kind of figured out all of that back end and how things were going to work, we workshopped the draft data collection form. So this is the form that the community is going to interact with. And we did this across 2 different co-design sessions. So the plan is to make those forms available in a digital format so they can be used on desktop computers, mobile phones, and tablets, but we'll also offer paper versions if local drug user organisations and harm reduction services decide that that's what's going to work better for their service users. So it's flexible, and that's really good. The co-design group has been developing a terms of reference for an implementation group, and this group is going to lead the rollout of the pilot phase of the community drug reporting system. Alongside this, we've been preparing a data management procedures document, and that document outlines how all the data will be reported, handled, stored, reviewed, and shared. So it's a really important document. And then the next stage of the project is the pilot phase. So we will launch this with members of the co-design group, and at the moment we're working through resourcing requirements and finalising logistics needed to move into that pilot phase. To finish off, I just wanted to say a massive thank you to everyone who's been involved in the project so far. We've also written a paper on the process, which all of the co-designers are authors on, and you can access that via the QR code, or I'll pop it in the chat. That's everything from me. Thank you.
Thank you so much, Molly. Great job. Really awesome presentation. It's been so wonderful to work with you and AIVL and all the co-designers on this project so far, and we're really excited for the pilot implementation. So thank you. And a reminder to everyone tuning in, if you've got questions, please just pop them in the Q&A and we can come to them when we have our panel discussion. We now have one final presentation, and it's a presentation from Jane Buxton. Jane was medical lead for harm reduction at the British Columbia Centre for Disease Control Canada from 2003 to 2022. And Jane advocates for engaging the experts, so people with lived and living experience of substance use, in all aspects of harm reduction. Jane, if you're there, if you're able to turn your camera on, and I might hand over to you.
Okay, hopefully you can see my screen.
We don't have your screen yet, Jane. We've got your face.
Oh, all right. Sorry about that. I will try again.
It looks like it's coming.
It's just taking its time. Can you see it? Gosh, it is slow.
Yep.
Okay, great. Well, thanks very much. I mean, this has been really great. I've enjoyed the 2 previous presentations. It's wonderful to hear what people are doing. And thank you to Lucy and Jack for inviting me to share the insights from British Columbia. The data I'm going to share are all publicly available, but some of the opinions will be mine. I have no conflicts of interest to declare. I just wanted to start with a brief orientation for those of you who perhaps don't really know where British Columbia is. We're the most western province of Canada, and we have about 5 million people, population just over, and we have the highest overdose rate and overdose deaths in Canada, which is nothing to be proud of, obviously. British Columbia, as we now call it, is the traditional, ancestral and unceded territories of more than 200 First Nations who have cared and nurtured the land for all time. The Indigenous population in BC is 6%, but is really overrepresented for those experiencing overdose and unregulated drug deaths. A little bit of context here. You can see that between 2000 and 2010, we had less than 250 overdose deaths in a year. In 2023, it was more than 10 times that amount. It was quite distressing how it had increased. We have seen a bit of a reduction in 2024 and 2025, but there's been 18,000 deaths since the public health emergency was declared in 2016. If we look at who is dying, 3/4 are male, 3/4 it occurs in residents, and 64% are found to have been smoking. So although it has come down in recent years, it is still unacceptably high for something that is preventable. And the cause, as you can see here, fentanyl has been identified in over 80% of deaths since 2017, and it'll probably be the same in 2015. We just haven't got the full toxicology results back. Another bit of geography, just so you can see, when we started seeing fentanyl, it was coming from China. There was then various regulations introduced, and we now are getting the precursors from China. So back in the 1990s, Vancouver was one of the Canadian Community Epidemiology Network on Drug Use site, and we produced an annual report, and there were sites across Canada, and we shared data and shared issues and data sources and material. But it was not at all helpful for giving alerts out. It wasn't timely. In 2011, the BC Coroner's Office put out an alert saying that there was potent heroin in the Lower Mainland. People made assumptions that because most of our drug use concerns have a reputation for being in the downtown east side of Vancouver, it was assumed it was there, and in fact it wasn't. It was in an area further east in the Fraser Health region. And also saying that there was potent or strong heroin, we heard that people would actively seek the heroin. So we decided to develop the Drug Overdose and Alert Partnership with the aim to collate data from across BC and ensure timely and accurate and consistent messaging so that the police would have the same numbers and have the same message as health and as drug user organizations. With the toxic drug emergency and seeing more and more deaths occurring, the meetings were monthly. And then when COVID happened, we changed to Zoom like we are now today. But it did mean that people with lived experience could attend from various regions, see the slides real time, and be able to participate and add their questions or comments in the chat. This gives you an idea of the different folks that were involved in the Drug Overdose and Alert partnerships. I think you can see that people with lived and living experience are really very important amongst this. But it also developed relationships. For example, in October 2014, Insight contacted the police about a sudden increase in overdoses. The police collected the implicated cookers and sent them off to the Health Canada lab to be tested. And there they found that substances that were being sold as heroin actually contained fentanyl. And that was when we started seeing that increase in overdose and overdose deaths. In 2015, we set out to explore how people assess their drug quality and drug alert communication. We did focus groups, and we found that drug quality information was primarily from a reputable dealer or from peer networks. The information from service providers was not really appreciated and not used. It wasn't valued. And then participants gave us suggestions on how to improve drug alerts, to use language that implies harm, describe the effects, to look for what the appropriate responses are, and to date posters and remove them. And it was amazing when we started going into various agencies to see posters that may have been there for a number of months. We have what's called the Harm Reduction Client Survey. It's a regular cross-sectional survey at harm reduction sites. and it's been there we've been doing it since 2012. And what we do is we work with people with lived and living experience, and we have a group called PEEP who are extremely valuable. PEEP started in 2015 as peer engagement and evaluation project. So we had 3 years of funding, research funding, and then it was deemed that it was so valuable to have input from across the province from a number of people. It's probably about 12 to 15, that it now is part of our base funding. So it's really nice to actually have something that isn't dependent on research funds and that is continuous. So any of the peers give us input as to what's the important things that they think need to be looked into and questions that need to be put on the survey. So we actually decided that we wanted to evaluate quantitatively what happened around how people were aware of drug alerts and what the outcomes were. We also felt, because we'd had a previous qualitative study, was before the public health emergency was declared and before we had drug checking and before we were seeing some of these adulterants, we felt we needed to do another qualitative study to inform the drug alert questions. So again, working with people with lived experience, we explored and interviewed 46 folks and had some focus groups with health service providers. And again, we heard that the dealers really found a trusted source of information, that social networks was a way of spreading that any information that was going. And then we should be using multiple approaches because different populations use different ways of communication, and social media for the youth. And we also needed to provide alerts in multiple languages. When we also heard from strengths and limitations of the different formats that we heard from participants. I'm not going to go through this, but I think it really emphasizes the need for different approaches. So what did we find in this quantitative study? We had results from 482 individuals who answered the question. 62% of these said that they had seen or heard a drug alert. 48% had heard from friend, peer, network, and dealers. 42% from a harm reduction site. 23% noticed posters on the street. Only, as you can see, 8% had received an email or text, but this was before the survey was done, before we had a province-wide text alerting system. And importantly, we found that 2/3 reported changing their drug use behaviours to be safer. The alerts that we have drug checking helps us be really timely. We have the test strips of fentanyl, benzodiazepines, and xylazine. And at point of contact, we have the FTIR, the Fourier transform infrared spectroscopy. We had radar, which was the real-time drug alert and response system, which in 2023 transitioned into a public health, toxic drug public health alerts for the whole province. We always try and emphasize the importance of naloxone. So even if the substances are containing non-opioid sedatives like benzodiazepine, xylazine, medetomidine, we still ask to tell people to give naloxone. This is how you sign up to join for the text alerts. You just put in alerts and then text join. You can also share events, overdoses, to tell folks about a toxic drug events if you text OD. We have another app that's run by Emergency Health Services for people using alone, who are registered, they'll press a timer. If they don't switch the alarm off in a minute, Emergency Health Services are contacted and will visit. But this also has the real-time drug alerts being sent out. So in general, what we heard about alerting, that we needed community input, include local peers. They're always the first to notice, excellent at getting the word out and making sure that the language is appropriate. Talk about harms, use appropriate language, translate, have graphics in case people are not able to understand too much text. Make sure that geography is relevant, describe the issue and effects. Don't do too many, because otherwise you'll end up by people be desensitized. Have multiple approaches, describe the drug effects, what to look for, how to reduce risks, and what the appropriate overdose response is, and then include the date that it's issued and when to take down. So I'm just going to give you a few examples. Excuse me. This is one that went out and we didn't know what was causing it, but it was deemed important enough that we had to get the message out. So again, what the issue, where it's occurring, what to do about it, and when to remove the poster. This is a provincial alert, which tells us, described as medetomidine, which we're seeing a lot of now, which is causing huge issues. And sometimes the issues are occurring 12 hours or more afterwards, with rebound, high blood pressure and tachycardia, fast heart rates. And this is a typical alert, which really gives a bit more information, where it's occurring, what the issue is, how to recognize, and that includes photographs, what substances are involved, so the different fentanyls, medetomidine, and various diazepines, what's the risk, what you can do about it, and when to remove the poster. So that was just some examples. Thank you.
Thank you very much, Jane. That was a really interesting presentation and great for us to see some of those examples of alerts that have been issued in British Columbia. Can I invite all of our speakers and panelists to turn their cameras on now? We have just about 15 minutes for a panel discussion, and I want to introduce two additional panelists. So we have Emily Ebden, who's joining us, and Emily is the president of the Tasmanian Users Health and Support League, TUSL, and has been working in frontline and systemic harm reduction for almost 20 years. And in more recent times, she's been working within peak organisations such as Input and AIVL. And Emily has been a real key player in issuing TUSL's peer drug alerts in Tasmania, and has also been contributing to our work on the co-design of the community drug reporting system. Welcome, Emily. And I'll also just introduce Clancy Beckers. So Clancy is peer lead at Newer, where they coordinate peer-led drug checking services at music festivals across New South Wales. Clancy contributes to drug alert decision-making processes and has been involved in the community drug reporting system co-design. And they bring both lived experience and technical expertise in harm reduction, policy, and practice. So I might just kick us off with some questions specifically for Emily and Clancy. If you have other questions, please pop them in the chat. But I guess, Emily, you've been involved in the proposed community drug reporting system that Molly spoke about. I guess thinking about Tasmania specifically, what kind of role do you think community reporting might play specifically in Tasmania, taking in the Tasmanian context into account?
Yeah, thanks, Jack, and thanks for having me, everyone. That really great question. Well, I would say, like every state and territory, we need a fixed drug checking service here eventually, ideally. And without having a mechanism like that, and as long as drugs are illegal, like we're fighting contaminated illicit drug supply, and with Tassie being where we are, like kind of an island state at the very bottom of the world, like our drug trafficking routes are just like, as Molly was saying, like Australia's quite a contaminated drug supply, then we're kind of almost even more so a little bit, just because we're almost a little bit more isolated. So and just to give you an idea too, like TUSL actually like reformed and relaunched as an organisation to respond to these issues and to basically put out drug alerts. Um, with the work with NCCRED and the early warning system stuff, I think one of the best things I'm excited about is having a standardized form to collect that data. And I think we'll be able to start using that like now, pretty much. And before that, we have been trying to do similar things. Like I know that the health department NSPs have an unintended effects form, which goes out and is capturing some of that data, but I'm just really looking forward to having more intel that's standardized to be able to put those alerts out even better.
Thanks, Emily. Yeah, we're excited about it too. And I want to throw over a question to Clancy. So, Clancy, you've also been involved in the community drug reporting system, but I know that you and your colleagues at Newer play a role within New South Wales in terms of deciding whether or not to issue drug alerts. And I guess I wondered if you could describe for us some of the key community perspectives or priorities that you and your colleagues bring to those discussions around whether or not to issue drug alerts.
Yeah, for sure. So the main sort of, I guess, mechanism in New South Wales is SPARTO, which is the Standing Panel on Toxicity and Risk. That's sort of a multidisciplinary group of people all around the state. But from Newar's perspective, the main sort of community lens that we bring into it is how we interpret risk and how we communicate it. So a big thing that we ask is, will this alert actually change what someone does today? Is the wording something people will trust and use? We try to avoid alarm for alarm's sake. We want messages that reduce harm, not accidentally increase it. Sometimes there could be panic that might come out of some sort of early warning signals that aren't really communicated appropriately. It could lead to, panic dosing, rush disposal, or even extra police attention that pushes people into riskier use as well. So it's sort of internally, we do a bit of a quick triage with what we're hearing through peer networks and service delivery and service users. We sense check it against other signals. So we do sort of, I guess, have a bit of we walk the line between the peer evidence and the sort of the visible evidence. Because a lot of the time when it comes to peer experiences, they essentially need to remain invisible for it to be safe, which can make this sort of data collection a bit tricky. But as we sense check it against other signals, we sort of bring the summary to SPARTO, and we pose our position about, who we should be focusing on, what language we should be focusing on, if it's worthy of an alert in the first place. And most importantly, the practical advice that sits along the warnings. A really important thing is that if somebody were to contact Newer, for example, with a report of a dodgy substance or a trend that seems concerning, then the best way that could appear is a week later, one of their mates sees an Instagram post about the exact thing that they just reported. And that's one of the main things that we try to do. It's about really validating those claims and sort of encouraging people to share what's further than just their experience, but trends as well, because that's what really ends up painting a picture that we can trust.
Yeah, it's a good point, Clancy. It's sort of that feedback loop thing, like how do we sustain trust in the system, information coming in and then going back out again. And Casey, you spoke a bit about that in your presentation. I think Molly mentioned specifically the data dashboards, which do look very impressive. I wondered, Casey, as well, in terms of, obviously it's been a very successful program that's run in Texas. Has there been any unintended consequences or things that you didn't expect which have arisen from the work?
Yeah, with our data dashboards, we had a lot of conversations with our community partners to determine the level of access. Who has access? Is it private? Is it publicly accessible, et cetera? We ultimately decided to make it not publicly available. And what I think an unintended consequence of that was the level of interest in our data. I never anticipated from the media how much they would want access to these data. They wanted to compare our data dashboards with like the federal data dashboards and the state level data dashboards. And there were discrepancies in the data, and we knew why. Our data, we didn't have lag time. Our data sources are very different, but it's very difficult to relay that to the public, and to journalists, for example. I think another unintended consequence that we experienced, I had no idea how political this project would become. Getting a phone call on my cell phone from the high intensity drug trafficking agency director saying this project is a matter of national security. We had to really balance how we involved law enforcement and the Drug Enforcement Agency. We originally did not want to include them at all, but we ultimately didn't have an option. So we ended up getting a certificate of confidentiality from the federal government, which protected our data in case somebody gave a court order and tried to access it. And so, we had a lot of protections, but we did have to balance those relationships with partners that we weren't intending to balance relationships with.
Yeah. That's it's really interesting, and I think that we could probably talk about that stuff for a long time. But I'm mindful that we've only got a couple minutes left on the call. And I kind of, you've touched on the fact that there was a lot of interest in the space, and that this is kind of quite a politically contentious domain a lot of the time. And we've seen some to and fro in terms of political contentions in the early warning space in Australia as well. And I wondered if I could throw this question over to you, Jane. I guess it's a question about how you maintain hope and resilience when there's difficult political decisions which are being made, which are affecting, change in this space or our ability to operate in this space at all.
Yeah, I think I've learned over the years not to take it personally. I think we all get very frustrated when you think you're steaming ahead and then suddenly something is shut down or somebody changes, and the sort of the political vibe is different. But I have found in times of stress and political adversity, people rally together, they support each other. You don't feel alone, even if you feel as though you're swimming against the tide, but you're doing it together. And I think that is so important, making sure that people with lived and living experience are involved and engaged and are part of whatever you're doing, and then celebrating even those small triumphs. You can't change the world, but you could do things one step at a time. And I have always been blown away by how creative and how people with lived experience can think out of the box and get around some of these things and are willing to advocate and say, hey, we've got to do something here. So I think it's really just working together, supporting each other, and finding champions, because sometimes you find them in the most unusual places, that you suddenly find that you have a champion who happens to be a enforcement officer. But, really you need to nurture them and work with them. So
Mm.
even when you're swimming against the tide, there are still things that we can do, and keep moving forward.
Yeah, I like that sentiment, looking after each other, maintaining those relationships and celebrating the wins. Thank you, Jane. I'm mindful we've only got a couple minutes left, but I might just throw one final question over to Molly. Molly, we've heard a lot about community reporting on this webinar today from different contexts, and just, I guess, thinking about the work that we're doing in Australia. To you and to AIVL, what do you think like success would look like for our community drug reporting system program?
I think there's maybe like there's two angles to that, and I think on the foundation, if the community has ownership over what goes into the system and also what's coming out of the system, then it will be useful and it will have impact. But I think also, um, beyond that, like wider in the sector, I think like demonstrating the value of community insight and community context will kind of support the embedding of living and lived expertise generally within the sector. Like, not to say that's not already happening, but I think this will be another really good example of how critical and valued that expertise is, and that often we can't get to the best outcomes for community without having that knowledge embedded, like not at the end or at the middle, but like from the beginning and being led by community. So I think it'll be a good example of that in the end.
Hmm. Yeah, thank you so much, Molly. We're excited to see what we can do as we look at piloting this year and beyond. Thank you, everyone, for joining us today, and thank you to our presenters and our panelists as well. I feel like we've had to cram a lot into this hour, and I feel like we could almost use another hour to unpack some of these, points that have been raised. Um, we do have a number of questions in the chat. If we haven't been able to get to those questions, then we will email you separately afterwards, just to follow up with you about your questions. Thank you again, everyone, and enjoy the rest of your day. See ya.
Bye, everyone.